Thank you, Professor Rohit Saxena. It's a pleasure to be again with the people who are interested in pediatric ophthalmology and strabismus. So we are going to talk on the management of Duane's retraction syndrome. And as you know, it's one of the common problems, and it's also a difficult problem to manage. Many a times we may come across the common type of DRS, that is the EZO DRS, and how it looks like. Do we have a laser pointer, sir? So the EZO DRS, which is, you are all aware, there is an EZO deviation in the primary position. On adduction, there is a retraction, narrowing of the palpebral aperture. Looking up and adduction, there is an upshoot. Looking down and adduction, there is a downshoot. And there is a limitation of abduction. So these are the primary features or characteristics of any DRS, whether it is an EZO or if it is an exo DRS. You may see that in primary position, there is an exo deviation. On looking adduction, there is again the retraction, narrowing of the palpebral aperture, and there is an upshoot as well as a downshoot. And of course, in spite of an exo DRS, mind you, there is limited abduction. So it's a pseudo abduction. Because it's an exo, it may appear as if the eye has moved so much, but if you see from the primary position, there is hardly any movement. So there is a limitation of abduction in many of the exo DRS cases also. If we had done a study on the MRI and we found many of these cases will have a missing sixth nerve. Abducens is missing in these. So if you see the innervational problem, the pathogenesis in these cases is that there is a primary disinnervation in the form of sixth nerve aplasia or hypoplasia, and a secondary disinnervation which is abnormal innervation by the nerve third, that is the third nerve. So what you find is sixth nerve is missing and the third nerve is occupying that vacuum and supplying in this. So that's why it is listed also as the congenital cranial disinnervation disorders. It fulfills the criteria of primary disinnervation and a secondary disinnervation. How these paradoxic innervations are creating the problem. So we need to understand that sometimes the eye in adduction is totally disappeared because of a marked upshoot, and these appear horrendous. How do we manage these cases? There is a very interesting phenomenon of Romero-Apis force degeneration test in cases of DRS. What is actually done is when you do an FDT, here when you hold the globe at the thing, ask him to adduct. Now what happens during adduction? The lateral rectus fires paradoxically in DRS. So you will find that there is a tightening on this position, and when you ask the person to look abduction in the direction of abduction, suddenly there is a give. And you will feel that there is a degeneration. That's why it's called force degeneration. You may be aware of force generation test. This is a force degeneration test which is done for a classical DRS. This shows that there is a co-contraction during adduction. So in the books you will find these listed. I don't want to make it a theoretical thing. You can go back and read the things. What we need to do in this presentation is to understand the problems. How do we manage cases of DRS? What are the basic problems? What do we achieve with surgery? One is reduce the co-contraction. Secondly, obtain the balance alignment in the primary position so that any abnormal head posture is also corrected. Obtain the concomitant rotation as much as possible so that BSV fields can be increased. It may not be fully possible, but it may at least improve upon whatever we have. And of course, accomplish the good cosmesis. So cosmesis is also a goal. If you want to read more, there is a very nice chapter by Jampolsky in Rosenbaum's book, which lists so many things that we need to take care of. But since it is a very difficult chapter to read, I would just like to make it a little simplified. So what are the considerations that you have to take in mind? One is whether it is an EZO, exo or ortho. So first thing is what type of deviation is there in the primary position that you should note. Secondly, is there a significant co-contraction in the form of upshoot and downshoot? Not all cases have in as much significance. Some will have more, some is less. So that is a point to be noted. Third, how much is the normal LR activity? So some will have a normal abduction, some don't have any. So that also we'll have to take into account. Fourth, force reduction test is positive or negative for MR or LR or both. So some will have, some will not. So you will have to see each case individually, they are different. The ideal solution would be to isolate the paradoxically innervating lateral rectus, correct the deviation in the primary position, and improve the abduction by a partial vertical rectus transpositioning. So in EZO DRS, what we will like to do is an MR recession. If done, we have to take care of minimal MR recession required as much as the tight FDT demands. So if there is a tight FDT, you need to do an MR recession of the ipsilateral eye. That is important. But you have to do minimal, mind this word. If you happen to do little more, you are in trouble. Why? Because there will be a synergistic divergence. The LR recession may require to be done if there is a co-contraction. So you need to balance the forces. If you are weakening the MR, the LR gets sudden hold. So co-contraction in adduction will create this. Now what you see here, it's an ESO-DRS, 4.5 millimeter of LMR was done, and suddenly the eye has gone into exo. There is a marked exotropia in this case because of a unrestricted lateral rectus nerve working. Earlier it was held in check by the MR. You have taken away the MR, LR is now free to do its mischief. It's like the police is on strike and the criminals have the heyday. So that cannot be allowed. You need to re-strengthen the police that way at least, or you want to catch the criminal. So what we did next day, LLR recession of 7.5 millimeter, if need be with a Y split because of co-contraction, and then you will be correcting it. So if there is an ESO-DRS, what you need to do is find out how much is the tight FDT. If the FDT is tight, you do only that much of MR recession, and if there is a severe co-contraction, always balance it with the LLR recession and a Y split to take care of this. So if you see, now the eyes are straightened, there is in adduction, see these pictures, the retraction, narrowing, all have improved, and there is no downshoot, slight upshoot is there, and this abduction, of course, we have not done nothing to improve, it is fine. Why a Y split is required? It prevents the eye flip for the muscle slip. So it is like yoking the muscle, which is a tight lateral rectus, you have split and make the globe so that it doesn't slip on the co-contraction, even if we are not taking care of the co-contraction fully. Remember, whenever we are recessing the lateral rectus, it's like a criminal being given little penalty. You are only penalizing it, weakening it, but it will reinforce itself with time. You haven't taken care of the mischief fully. What are the other management strategies? Especially in exo-DRS, you can do a Y splitting with LR recession. You can do a severe weakening of the LR by 12 to 18 mm, or you can do a periosteal fixation of the LR, or you can extirpate the LR altogether. Just take the analogy of a criminal in mind or a terrorist. What do? You can weaken it to some extent, it will come back with vengeance. So you need to do these two things ideally, that you put them in the dungeon or you extirpate it fully. Now we had a case in which there was a bilateral DRS. We did 18 mm of recession in the right eye, and you see what is happening. In spite of our efforts, there is still a narrowing in the right eye on adduction. The left eye, we did the periosteal fixation, and you see how much improvement is there because of that. So we need to be more radical in our management. But remember, in exo-DRS, little is no good. Reverse of MR in ESO-DRS. You have to do minimal MR recession in ESO-DRS, and nothing is enough for an LR in exo-DRS. So you have to do even more than 18 mm, 21 mm, or even so this case which was operated elsewhere, which came to me with such a large, in spite of LR recession done 8 mm, and IR of 6 mm was done, which was not required. And what we did was this, and we found that it was fine. So we need to see a practical approach, and after periosteal fixation, such cases are fine, well handled. Ortho-DRS have to be handled a little more carefully because they have primary position alignment, but they have a problem of upshoot and retraction and narrowing, which is bothering them, so they come to you with hope. And what we can do is a balanced approach of both the MR and the LR, and then we can have the correction of the primary position maintained, the correction in adduction, and upshoot and downshoot also corrected. So in ortho-DRS, the management is that. I think we may not have time to run in for different types of cases, but sometimes you remember in ESO-DRS, we may handle the ipsilateral eye only 3 mm, and if the ESO is more, but the co-contraction doesn't allow you to do more, you can do the other eye MR recession of more amount so that you can correct it more equitably. So that approach may be there. And in exo-DRS, I have told you the possibilities. You may do in children, particularly 18 to 20 mm, if you don't want to do periosteal fixation. Otherwise, periosteal fixation is a good strategy. So to conclude my talk, remember what we do. MR recession alone or with LR recession with Y split, especially whenever there is a severe co-contraction. If the co-contraction is not much and it's an ESO-DRS, you do the minimally required MR recession alone. If you do a VRT or a superior rectus transpositioning, remember you may spoil the situation. unless you are taking care of co-contraction. LR is still working and you are supporting it with the SRT, superior rectus. You may worsen the co-contraction, be aware of it. So in exo-DRS, what do we do? Periosteal fixation of the LR and split VRT to improve the abduction. Differential MR and LR recession with Y-split for ortho-DRS. So I think in short, depending on ESO or exo-DRS, this is how we will manage them. Thank you all.